Good evening, everyone, and welcome once again to the 66th episode of the Gyan Pravah podcast series, which is one of the brilliant and out of the box initiatives of our dear President Fogsi this year, Dr. Sunita Tandulwadkar. I am Dr. Sita Ramamurthy Pal, Chairperson of the Genetics and Fetal Medicine Committee, and I'll be the host this evening and on the 4th of every month, where we will be engaging in interesting conversations with some of the legends, experts, trailblazers in the field of genetics and fetal medicine. And one such expert and trailblazer today is our guest speaker for this evening, Professor Dr. Ratna Duvapuri. And our topic of discussion will be genetic revolution, transforming science, medicine, and society. Thank you, Madam, for accepting our invite and for being with us today.
Thank you. Thank you so much.
Before we start our conversation, I would like to say a few words, formally and informally, about our visionary and dynamic president of Fogsi this year, Dr. Sunita Tandulwadkar. Madam, after taking her presidency this year, in a span of 3 to 4 months, I must say, has managed to touch the lives of every Foxian and the women across our country through her multitude of projects, some of which is the Arogya Yoga Yatra, which is combining spirituality with medicine. Know Your Numbers, where the initiative is to let every woman be aware and transform her numbers of four important numbers of hemoglobin, weight, blood pressure, and blood sugar, so that she's aware of it throughout her reproductive life. Do Teeke Zindagi Ke, which is the campaign of vaccination against prevention of cervical cancer. Sampurna Matra Abhiyan, which is complete care of the women and make sure that she enters pregnancy. It's a planned one and a complete one. And this Gyan Pravah podcast series, which has been such a brilliant and popular series where all of us chairpersons are able to interact with different experts, not only in the field of medicine, but in technology, spirituality, political, and we ourselves are gaining so much through this. And thank you, Madam, so much for this initiative. Apart from this, Madam is a brilliant laparoscopic surgeon and an IVF specialist, and she's the current president of Foxy and the president-elect
Thank you, Seema. Thank you,
and
Seema.
president of the Society of Ovarian Rejuvenation, where she's done some breakthrough work in the field of stem cell therapy. Madam,
Thank you,
requesting you to say
Sita.
a few words.
Today is your day with Dr. Ratnaji. So thank you so much. Always being so kind, so humble, and very sincere, honest chairperson of mine. I'm tremendously proud of you, Sita.
Thank you so much.
Tremendously. Ratnaji, these 30 committee chairpersons doing 30 webinars. I should not say webinar, I should say podcast series is really the most important Foxy presidential activity. It's becoming like that because every chairperson who are future leaders, they take the interest, they select the topic. Now I'm sure today, Sita, 4th April done. From 5th April, she will start thinking what
Yes,
will be for 4th May on my plan.
absolutely.
Everyone wants their podcast to be better, more informative to the viewers. Sometimes the viewers may be non-medical. And I think with the simple dialogue, we are really enriching their knowledge as well. So, Ratnaji, thank you so much for coming today on our platform. Foxy welcomes you. And I'm sure this is, Sita, your both the previous podcasts were out of the box. Fantastic. Even with Dr. Suresh, I enjoyed like anything. See, out of those 67 podcasts, if I remember your faculty so well, it means that podcast was absolutely a memorable podcast.
Thank you.
So I'm sure with your podcast, with your dialogue, you will simplify genetics, which most of the gynecologists fail to understand. And probably they will become so confident. Don't worry, Ratnaji, our patients will still come to you.
No.
It's my mission in life to make
genetic literacy. It's really.
Thank you. Thank you for that.
Thank
And
you for this
more
platform for that.
more and more you listen, more and more you enjoy. So I'm sure our way is I join from the viewers' links once Sita introduces you also, and we give you a gracious welcome, and then I will join the viewers' link. Back
Thank
to
you
you,
so much.
Sita.
Thank
Thank you.
you. Thank you for your kind words, madam. So, genetics is evolving rapidly, and we have actually come a very long way. And to discuss this major revolution in present day medicine, we have none other than a true pioneer in the field of genetics and beyond, an inspiring teacher, Professor Dr. Ratna Duapuri.
Thank
Madam is a professor in genetics and chairperson, Institute of Medical Genetics and Genomics, Sri Gangaram Hospital, New Delhi, and she's also the president of Society for Indian Academy of Medical Genetics. Madam has received multiple awards like Dr. I.C. Verma Outstanding Researcher Award 2019, Dharam Veera Award of Excellence 2010, and Young Investigators Award Tokyo, Japan in 2006. Madam is a member of the Undiagnosed Disease Network International of NIH, USA, Diagnostic Scientific Committee International Rare Diseases Research Consortium, and panel of experts of the WHO Collective Global Network for Rare Diseases, Rare Disease International. Madam has a research interest in Indian Undiagnosed Disease Program, artificial intelligence and genomic profiling and diagnostic yield, and familial hypercholesterolemia. Madam has a number of publications and citations to her credit, but besides her brilliant academic career and achievements, Madam is a truly inspiring leader who actually carries wisdom, humility, and kindness in equal measure. I think her kind and reassuring words, her gentle words, makes even the most complex genetic topics so easy and so approachable for us. Madam is just a phone call away for all our doubts, and as rightly said, she is the last word in genetics in India and the voice of genetics in India. So, as Madam's mission is to make genetic literacy more common in the field of medicine here, we welcome you again, Madam, to this podcast series, and thank you once again for accepting our invite. Thank you so
you
much.
so much for that very, very kind introduction. And I think it's a privilege to be here. And I would like to thank Dr. Sunita at the outset, as well as you, Dr. Sita, for allowing this platform, just for sharing knowledge and information. Thank you.
Thank you. Bye. Thank you once again, Ratnaji, for coming on Foxy platform.
Bye-bye.
So, Madam, as we start, we knew that you started your journey as a pediatrician and then you moved into genetics, and it has inspired so many of us to take up genetics, nowadays. So, what inspired you and what has transformed you to this, got you here so far?
Sita, it's been a journey that I never imagined. It was absolutely unplanned. I was a pediatrician, as you said. My husband was in the armed forces, so we were moving stations every 3 years. And so I had only one mission in life, and I had to live together. I was not going to live in two different cities, bring up my children. I have two boys. And so moving along with him, we reached Lucknow. I sat for the exam and cleared the exam. And even once I cleared the exam, there was absolutely no thoughts in my head of doing a DM degree. It was 10 years after I
That
had done
time, yeah.
pediatrics. And so I really have to give a lot of credit to my teacher, my mentor, Dr. Shubha Fatke, who said, well, it's DM or nothing. Take your pick. So that's how I entered DM genetics. And actually, when I entered it, I didn't know what I was in for because there was hardly anything in the early 2000s in India about genetics.
Yeah.
PGI Lucknow, where I trained, was the only center in the country offering a 3 years DM. And then slowly over the years, at least I just fell in love with it. And that was the journey. That's how it all started.
Fantastic. I mean, I can imagine at those days and age where none of these tests were available, convincing patients to know, it must have been a arduous task for at your end, very few of them offering, and why are they offering those sort of questions in their mind?
Everything was clinical then.
Yeah.
So there was karyotype available, there was no microarray, there was fish available. And at that time in SGPGI, we used to do fish tests, the probes used to be there. And so that was done. There was some simple single gene disorder test, like the DMD, and Fragile X was set up there by a very complex southern blot mechanism. And so it was few and far between. Thalassemia, of course, thalassemia was being done. And we also used to manage children and adults with thalassemia and hemophilia,
Mm.
did a lot of dysmorphology, but that clinical era is the one that has actually laid the foundation, which I really like to insist, at least for our residents, that the test will not teach you anything until you actually examine a patient, you speak to the patient, you take the details. And I think that is what those years has instilled into us, so that over the years, this whole transformation that has taken place with the advanced testing being available, we are not lost within the realm of tests without knowing what we are doing. And I think that that was a very, very important era, which kind of like put us through all this, and it worked well.
Interesting, yeah. So, madam, what, in your opinion, what would you say, when you're talking about genetic revolution, what would you say are the biggest breakthroughs what we've seen in the last 1 or 2 decades in the field
Yeah.
of genetics?
I think the first thing that really came up, of course, there was PCR, Sanger sequencing. So there were things that started genetics, being able to look at chromosomes, but that was all there when I started my training. But over a period of years, what had really started then and came up while I was training was the first human genome project. That really, it took 10 years because that was what was, those were the tools that were available then. And it took 10 years what you can do in 24 hours now. Okay, it gave you the basic reference human genome, what normal people have, which we use all day long really to refer to filter all these next generation sequencing data that is received. And it was because of the Human Genome Project that technologies came up, you know, and they became more and more advanced, and the costs came down as the technologies became better. And so that is really responsible for bringing a next generation sequencing into our clinical practice. So I think that was one. And and beyond only looking at exomes, there's so many, I mean, that's just 1% of the genome.
Yeah.
Looking at regulatory regions, looking at other parts of the genome, all of which are very important for, um, for the normal human body function.
Mhm.
So that was really a revelation through that. Then, of course, there was gene editing, recently CRISPR-Cas9. That has really, really been very important in bringing in therapeutics as well as diagnostics. You know that in India in COVID-19, they use that technology to get that very rapid COVID-19 test.
Yeah.
So, and then of course, things that we had never seen were these definitive treatment for genetic disorders. We always had, the heartache of telling patients, I'm sorry, your child has this. We know what he has or she has. We know why it's there, but we have no way of sorting it out. But now, of course, more and more gene therapies and different ways of treating genetic disorders has come in. So these have been great changes within the landscape of genetics.
That's amazing. I mean, gone are the days where I used to just give up hope on these patients. But is it true that we're actually able, I mean, with CRISPR coming in such a big way, is it actually true we are able to cure, or we just, managing them better
So you have to understand, the minute you edit a gene, you are making the normal gene.
No, you're making it
That
normal
per
from an
se, yeah.
abnormal.
So that per se is cure. But what all these disorders are teaching us when we are treating them, like when we started treating infantile onset Pompe disease by enzyme replacement therapy, which is another form of therapy where we are giving the deficient enzyme into the body, children who had never lived beyond their first and second birthday started living. And when they started living, we started understanding extended phenotypes. And we started realizing in the genetic scenario that it's not enough just giving it into a blood vessel.
Yeah.
We need to target the muscles better. But that realization only started coming in once the children lived longer to show.
Started living longer. Yeah.
And so it is the same with gene therapies. We have been involved with giving gene therapy for spinal muscular atrophy, which is a very, very severe disease, and especially type 1. Again, the children would die after their first or second birthday. And now you're realizing that as these children who never ever even sat are standing with support, what are the additional things that are required? And then you think, well, it's the anterior horn cell in the spinal cord. Again, is it going to be better if you're going to deliver the gene therapy there? Or is it fine if you just give it into the intravenous vein? Because how much of it really goes into the spinal cord? So the next trial that happened was of giving intrathecal gene therapy. So it's an evolution. So while you're curing it, but the impact of it really comes over a period of time as you understand a phenotype which was never there because the children never lived to that age.
Oh, that's so interesting because,
As
it's fascinating. Yes. I mean, as you sort of live, you're going to, I'm sure it's more and more things are going to come up as to how you target there to be a normal functioning individual.
and this is, Sita, this is new. Let's talk about thalassemia.
Yeah,
We were giving them blood transfusions
all throughout.
for years.
Yeah.
And then so much iron started getting accumulated. So, initially it was just parenteral removal of the iron. It was painful. The whole night the children had to have this desferoxamine infusions to remove the thing. Then the tablets came, and then better tablets came. So the whole scenario over the years has changed. And that's a disease that, has been known about for years. There was treatment for that. We now have gene therapy for that. So it is all these breakthroughs in science which has enabled this.
And I think that's an important message to, our general obstetricians or whoever is in the community as well. When we talk to such couples who might want to continue the pregnancy, whatever it is, to give them the option that it's not the end of the world for them, isn't it? And to get the right direction.
Absolutely. And as we understand more and more of genetics, this sort of counseling to terminate a pregnancy is becoming more and more difficult. Now, where you have severe intellectual disability, it's all right. But when you have mild, maybe moderate, you have a sort of a gene change, which is reported in literature not to cause a severe disease. I think it is our duty to inform the patients about that. We should not be convinced that the patient will just want to, discontinue our pregnancy just because there is a gene change there. The patient would want to know, what is the problem my child is going to have? There are not too many situations where we can be very categorical. We can never be categorical. It's science. I always tell my patients, science never 1 + 1 makes 2, unfortunately. But, well, yes, if something has been reported, we have to take the time and the effort to go back into literature, review that, call the patient back, tell them, well, though this is a severe disease, but this specific gene variant in that disease has been reported to cause a mild phenotype. And what does that mean? What are the implications of that? And I think as more and more people are doing genetic testing, not just ordering the test, but being able to interpret that report, being able to review for that report, and guide their patients correctly. Because I always say that it is a life. It is a life that we are taking when we tell them this is not okay, just go and discontinue it. And we should not take it lightly.
Absolutely. And some of these patients, very sadly, when they come in their next pregnancy, they do tell us that we weren't given any options. We weren't told of any other options. We were just told, like, nahi ho sakta hai. This is the end of it. So that's sometimes, I feel very unfair on these patients.
I think we have to enhance our sensibilities. And I think, especially as women, especially as women.
True, very true, madam. So, what about fetal medicine? How has genomics, changed fetal medicine with all these technologies, especially because we are trying with advancements in ultrasound, we are detecting more, we are able to counsel more, but at the same time, when it comes to genetics and genomics here, that has also evolved rapidly, isn't it,
Yeah,
ma'am?
that's true. I mean, you all are identifying so much that it's difficult to keep pace with it. And I sometimes say, oh my God, now what?
Mm,
But yes, that also has actually, the advances in genetic testing has revolutionized the practice of fetal medicine. And again, I say, I think the onus of all these advances, and as you know, that the onus of doing a good scan is so important and it rests on the doctor. So similarly, ordering the appropriate test, not ordering a test when it's not required, I think that is more important.
that is more important, yes.
And interpreting the test correctly is very, very important. Because sometimes I've started feeling that we need to remind ourselves that pregnancy should be a very happy, happy time in the life of a woman. And even when the tests were not available, 95 to 98% of the pregnancies were normal. It's not as if we landed up with more genetically affected children. Yes, when we have technology, we need to understand what we have to do. Like you have to screen for major malformations, you have to screen for anencephaly, neural tube defects, etc., etc., and all the lethal anomalies. That's very imperative because the morbidity and the mortality is high. So similarly, the use of genetic tests in fetal medicine, when there are risks either related to a carrier status of something, be it a balanced translocation or be it a severe single gene disorder, we must do the appropriate prenatal diagnosis. When we see abnormalities, not subtle differences, we all look different postnatally, and I would presume that prenatally all fetuses look different. And so we should not do genetic testing for differences, but we should do it for significant things where we know that the report of that test can probably influence the decision of the family to continue or discontinue a pregnancy. And simple examples are a cleft lip palate, a CTEV, where all these, in fact, today only in my OPD, there was a child who came in and we had followed through the pregnancy of that couple where CTV was identified. And I took them through their series of tests, scans, and um, really encouraged them to continue the pregnancy because it is a very, very treatable malformation.
Mm.
So the child had a positional CTV, which is not something really you can make out in the antenatal scan, if I'm correct, whether it's a fixed deformity or it's going to be positional, which just by PT or maybe a plaster is going to correct itself.
True, that way.
And something that really stuck to my mind, and I tell you, if you hear your patients, it is these things that push you along. A path where you know that what you're doing is right. He says, I just came back to say thank you so much because we wouldn't have been able to go through this without your support to give birth to our daughter, you know. So these are things that really stick by you, and I think they encourage you to actually support the families and not, really worry them so much.
Yeah, we've had
Not
experience.
to terminate pregnancies where we can easily manage them.
True. Similarly, I had a case where she was referred for termination because she was 23 weeks with a CPAM. and there was nothing else, and this child is now healthy, and the guy is actually a OT technician in our hospital. So because he knew that this was there, and and we feel so good, we feel so encouraged by such families. We're so grateful because we let them have the child.
Absolutely, absolutely. That's
But
true.
but at the same time, it's important, isn't it, madam? Like now, even with and some major anomalies, people defer from doing tests, and because it has an implication for recurrence, and that is what we are trying to in.
Yeah. So I think for all general obstetricians who are seeing this podcast, it's important to understand why we do genetic tests in pregnancy. So one is, of course, if there's something like you said, a CPAM, really in CPAM, we wouldn't do anything. But if there's something like a clubfoot or a CTEV, where it will influence their decision making, because if there is a major chromosomal abnormality associated with ID, they may not continue. But if the genomic tests and the chromosomal tests are normal, they would continue. The second situation is when there is a very major abnormality. For example, there is a lethal skeletal dysplasia. And in fact, today only we had another set of patients where 2 pregnancies, no children living, very severe cardiac abnormalities, but no DNA of the child was available. And then by just doing the testing of the couple, we are not going to be able, I mean, we were not able to identify what was there in the babies. And so therefore, the second indication of doing genetic testing when you have these sort of problems in pregnancies where the outcomes are not going to be good is to do testing to inform the cause of that specific abnormality, because that information would guide us on how to prevent the recurrence of that in a subsequent pregnancy. Now, if you're very sure that that lady is going to deliver in your hospital, you can do it after delivery. However, most of the times it's not like that. They go to different centers, they deliver. Then it's probably appropriate to do the test before and at least store the DNA of the baby before, and speak to whichever gynecologist is going to deliver, so that also you have additional postnatal phenotypes. So these 2 things I think are really important because the test cannot be interpreted without a good phenotype.
Absolutely. And madam, you, as Indian Academy of Medical Genetics, have really come out with, this carrier screening, which is so important nowadays. We knew about thalassemia. Can you just tell us the importance of carrier screening now, especially with SMA coming in the picture as a routine? We should be including that, isn't it? I must say it will make a lot of impact if it comes from your, you
Yes.
seeing it.
So to put it in the correct perspective, in every pregnancy, we know there is a 2 to 3% chance that the child could have some genetic abnormality, whether it's a malformation or it's a chromosomal disorder later associated with ID, or a single gene disorder associated with any form of a genetic disorder. Now, we know that the carrier rate, a lot of work has been done in thalassemia, and we know that the carrier rate of that is high in the country. And so therefore, there are these guidelines from ICMR which says every lady must be tested for her beta thalassemia carrier status. Now, we also know, and we have data from India, that tells us that the carrier rate of spinal muscular atrophy is equally high. It's as high as that of beta thalassemia. It's about 1 in 40. So the chance that 2 partners who are carriers, because it's an autosomal recessive disorder,
Like
the
that.
chance that 2 partners who are carriers get married, even if they're not from the same family, it's a non-consanguineous marriage, is high. And because we have data that talks about the carrier rate of spinal muscular atrophy in India, the Society for Indian Academy of Medical Genetics, along with the Society for Fetal Medicine and Fogsi, have come up with these recommendations that say SMA and beta thalassemia screening should be offered to every pregnant woman, because both these disorders are difficult disorders to treat. And though there are multiple therapies, there are 3 forms of treatment for SMA, but they're not easily available to our patients. So it's
You should be
actually,
aware of it at least before
yeah,
they on this,
Yeah.
isn't
And it's equal to not being available. A therapy available in the US and not to you, it's equal to not being available.
it? True.
So therefore, the recommendations say that for these two conditions, we must do carrier screening.
So I think as part of hemoglobin blood group, it should be our practice now to start writing for screening for SMA. I think that has to be instilled in every obstetrician's, practice now because it's
Absolutely.
because it's still not picked up as much as thalassemia. I mean, now people are able to write about thalassemia,
We
but I
can
hope it doesn't take the
wait
same amount
20
of
years.
time. Yeah, that's what I hope. It doesn't take the same amount of time for SMA, where we know so much has happened. But madam, as you have been through the years, how is it? What are the challenges that you've faced, especially with our Indian couples, about these screening or implementing these genetic technologies as well, especially in our part of the world? Where resource settings is important, cost is a factor, and then societal pressures that come up with every pregnancy. So what are the unique
Yeah.
challenges that you have faced?
So first I have to say is our own literacy, the literacy of the doctors. If a doctor is convinced, we can convince our patients. It's not difficult. The second is the cost. The cost of these genetic tests is high. And, it's not as if it's covered by either our insurance or it's covered within any public health platform. But we do know that there are many public health hospitals in our country who are offering genetic tests. So if you really find that a patient cannot afford the testing, it's fair to get it done from any other center. Okay? There are many public health hospitals who are offering genetic testing. And I think the third is the follow-up. The reports don't come back immediately. And sometimes you have patients who are coming late in pregnancy because the doctor had called them for a visit, say after 1 month or 2 months or 3 months. And before you realize that the pregnancy is advanced, they are actually carriers of something. And, because it was supposed to be a sort of a routine visit, and the patients don't look at the reports or they're not expected to understand the reports. So we have many things that we have to put into place. We have to put into a sort of as long as there is out of pocket expenditure, there are going to be challenges for these genetic tests. And therefore, I think until things get streamlined, it's not as if in such a 1.2 billion population, we can expect the government to pay for all tests. It's not possible. It's not even possible that the public hospitals can bear the load of testing all, but a lot is happening. And now genetics is coming into play at a very rapid pace. We are going to have centers in every state, hopefully, where at least the basic genetic test, prenatal diagnosis for beta thalassemia, newborn screening, all this is done because I think it's high time. And, then the state machinery can clock in and, work things together the way Kerala has done it. They are a brilliant example of how things can be done. And so once if we have our literacy, we understand that we don't have to do every test because we cannot ever, even if we do all the tests, give 100% guarantee that everything is going to be fine. So I think we as doctors first have to understand that we have to expect and accept that no matter what we do, you could have a child with a genetic disorder. So many genetic disorders happen by chance. They are de novo. They are because of changes that are not inherited from the parents. So these sort of things can always happen. So I think we have to understand, let's do basics for everyone. And then beyond, as the family history is, or if there is consanguinity, then in those situations, we can streamline advanced testing.
So that would also imply that, having equitable access for all these patients to get for genetic tests, so that if they have the basics of testing, like I know of medical colleges are not even able to give them combined testing. They just do an NT scan. In some of the medical colleges here, they don't offer the combined testing. It's only if they can go on to private and do. I think such basic tests at least should be offered. So it's
I agree with you. I know that in all medical colleges, even beta thalassemia screening, HbA1c hemoglobin A2 is not available, you know. And I think that it is a lack of focus. I think that, you know what, I always feel that there is something wrong when we say that we don't have enough doctors. I know of enough doctors who don't have good jobs. है ना?
yeah,
We are in the most populous country in the world and we say we lack expertise. How can it be? We are just not,
right.
working on it properly. We haven't streamlined systems properly. Everything is haywire. Every day the other day only in the newspaper, I read that we are so short of doctors in specific places. So those are things so it has to be a lot of administrative and political will. I don't think it's in our hands to do it unless we become big administrative tycoons. Yeah. Then the problem is by the time we all reach there, we forget grassroots. And so I think that we must focus on that.
Yeah, very
Our
true.
patient load is very high. And unless we have appropriate doctors in all the places, you cannot have these tests being added on because they're already overloaded with the work they are doing. है ना?
Yeah, yeah,
And so a doctor has to take the responsibility for starting these things. And the administration has to take the responsibility of ensuring that the supply of the chemicals and the kits is uninterrupted. Once
publicly adequate.
all that will comes in, only then will a certain basic minimum care be possible for the general population in public sector. So I think things are improving,
Yeah.
but probably, I don't know, maybe a Foxy president can take it forward. She has all the brilliant way forward on how can we empower basic medical care, basic obstetric care, since we are dealing with Foxy, for our general population. I truly believe with you that at least tier one care, which involves, making sure there's no anemia, making sure she gets preconception folic. Why don't we have folic acid fortification rather than still having neural tube defects because she did not take preconception? Majority of them are unplanned pregnancies.
Yes.
It has nothing to do with the sector, what segment of life we are in,
Yeah.
of society we are in.
We still
And
have
so I think we still have to work, but I feel that over the years, little bits that are done by everyone adds to it, and we will get there.
Yeah. Yeah, we need people like you, madam, to give us the right direction. No, it's very important because the actual, the when we have the political or the government, we need people who can advise us or guide us, and which is the best way, isn't it? Thank you.
That's true.
So, madam, in our society, obviously, we have a lot of, cultural and the beliefs and traditional beliefs when we talk about these doing this genetic. Have you ever encountered these sort of, you know, challenges coming up in the way of genetic testing or doing any, even terms of autopsy when we nowadays sort of, stress on to get a right diagnosis. So because of these different cultural and belief, social norms that we have, um, do they pose a challenge as well?
Well, yes, they do. They do. And I think, again, a great deal of sensitivity is required to deal with that. And it starts from talking about X-linked disorder carrier status. I never directly tell the couple that the lady is a carrier. There are some norms you understand in your society. If I were
Absolutely.
living in the UK or US, it may be different, but I'm not. I'm living in India. I understand that women in my country are a slightly marginalized community.
Most
Most,
likely.
I'm being very
Very
polite,
modest about it. Yeah.
and most of them, and therefore I will never ever say it. But at the same time, you have to be careful not to give incorrect information. And so while it's important, we know that carriers may have problems, you have to look after their cardiac status as they grow up, etc., etc. You have to gently balance everything. Okay? Once that the family who has come with a child with Duchenne muscular dystrophy becomes comfortable with you, and then down the line you can tell the mother, maybe you should get an echocardiography done, and maybe we need to look at your heart muscles, and then you tell the couple that it's fine right now to manage that boy. If you have a girl, when she grows up, make sure we do carrier testing so that you know that she has the option to decide what she wants to do. So there are ways to go about it. When a consanguineous couple comes in, you won't say that just because you're married in blood relationship, things would be bad. You would say, I've never had a problem in all my family. Everybody is consanguineously married, which is true.
Yeah.
It only increases the risk double. And similarly, it is for our endogamous communities. So many years ago, when I had just come into my specialty, and we used to get so excited when consanguinity and big family histories would come in,
These
or
are like
communities, and you'd say, oh, I know this community, let's do this gene test. And now it's a nice sign with the resident who's with me. Calm down, calm down. We have to be gentle. Because as
sensible.
far as they are concerned, that is the system in their community, and that is the accepted norm. And so, if as doctors we find that they are slightly increased risk, we just evaluate for them and talk to them about it. So it's very important not to take away the basis of faith
Mm.
for anyone. I think is very, very important.
Very important. True. Once they believe that you're not thinking in their way, or that faith is lost, they'll never return to you, and then you've lost them.
And they can't change the systems,
Yeah.
Once you come
They
to
have to
know
go
the
back to that
family,
society.
yeah, they have to go back. And once you come to know a couple, it's fine that you tell them, maybe we should avoid marriages within the community. वो खुद ही आके बोलेंगे, डॉक्टर साहब हम तो ये समझ ही गए, आप आपको बोलने की जरूरत ही नहीं है.
Yeah.
So, but it takes a while. It's not a discussion where it's ever a discussion that we have in the first visit.
Mm.
Because each one of us is a carrier for something or the other. And that's how I start. I said every human being on this earth is a carrier for something.
Something.
And so we just want to match both partners carriers for the same gene, and then inform the rest to you to make you take your decisions.
And that's why the rather screening for thalassemia is also sort of difficult, isn't it? Because when families know that they wouldn't want to work, that's becoming a challenge. But yes, we are getting
Premarital screening in our country will
will
not
never
work.
happen. Yeah.
No, it's not the right thing. Sometimes we have these women who come back for CVS who are carriers. They have not told their extended families on the husband's side. And so I just, by the way of conversation, asked them, I said, does your husband know? And some of them say yes, some say no. But that's the community and the society we live in. And so we have to form our own norms. It's fine. Let her come to her mother's house, get the test done, and go back. And if the fetus is affected, they say bleeding ho gaya. We have to live within our boundaries.
True. Madam, you're so inspiring. You're so soft-spoken. I think your service background that you hail from, I think that has a lot to. Do you never get, sort of flustered or agitated, because we've never seen you like that? So some words of, wisdom there, or, how do you deal with patients who might irritate you for some time, or.
Yes, some do really. When
That's something we have to learn from you.
no, I also lose my cool, but then I think that the patient is there because he's a patient, and so it's not correct. And so sometimes you take a break, or somebody else comes in and tries to explain it in a different manner so that the patient understands. And So I think it's only over the years that just speaking and speaking, and I think God just gave me the ability to speak. It's not something that I really worked on. But yes, it has helped me. My it's just helped me because I feel a lot for the patients. And I think many incidences while I was growing up in the specialty probably did that. And I saw that, I mean, it's so difficult. Can you imagine families where you have children with genetic disorders that are not lethal, but in the first 2 years of life, the children live on. And you see it and you appreciate how much of an impact it makes on their daily living, not just coming for doctor visits. Things are not easy in our country. If I say go get physiotherapy done, the lady has to go, she has to give up so much and get it go every day for physiotherapy. She has
There's
to
other things
travel.
to look after.
They have to earn money. They have to work hard for everything. It is not easy. It is not easy. And I think over the years, just seeing how much these families do, yet they smile, yet they form parent groups and they work for the cause of that disease. Oh my God, we've got nothing to complain about. And I think that mostly has impacted my ability to be able to understand, to talk to the families, especially the children who have the genetic disorder. And also to show the families that if God takes away one thing, He gives many more things.
There's
And
always
so it's for us to recognize that in the child. And because you have to help them, take things forward.
yeah, and I think the
It's
children are the best.
devastating. The first visit is always devastating to tell the family that your child has this disorder. It's because until it is confirmed, there is a denial.
Mm.
And even when it's confirmed, there is a denial. But things start seeping in. And then they will ask, okay, we'll do this with my child will become okay. I know that their child is not going to become okay. And so over the years, I've said, okay, it's our job to develop him to the maximum ability. That is our mission. And, so step by step, you have to help them deal with it. It's not easy for them at all.
Yes. And it's the children as well who inspire you to encourage them, isn't it? Because they are the ones who come up with a lot of hope and
Absolutely.
seeing them grow is so important.
And especially for those disorders where the intellect is good, the child understands everything that's happening.
Yeah.
They are the ones who really inspire me because it is these children who grow up and do so much more. I always used to tell my children, I said, you guys have been born with a, golden spoon in your mouth with everything. You never, they would say that, my God, we have to go and stand in the line for a doctor. And that is what kind of like shook me. I said, do you know sometimes how much a patient has to wait because I can't hurry up? I have to see them slowly. And once when they had to wait, they understood because normally being a doctor, you just tell your colleague, I just see my child.
True, true. Absolutely. No, I think when you don't have something, you appreciate what you don't have and you see the importance of other things, isn't it? So that's always, yeah.
It's absolutely like
It's amazing. Madam, you've done a lot of work in terms of genetic research, and so can you share some success stories that, as in India, that we've had in terms of genetic research? We're so proud of you and your work.
so it's not only me. I have to say that um, as I lead the Society for Indian Academy of Medical Genetics, I'm so proud of this whole genetics community. And it's brilliant of the hard work everybody is doing, how much everybody has achieved, how they have adapted to new knowledge. What we do now was never anything that we ever learned when we were training. So everybody has learned, kept up to date, and not only done clinical practice, but along with clinical practice, also done research to understand our scenario. And, you know, just a little story, because this involves not only me, it also involves antenatal scans and, the extent of amazing scans, and also um, a little sharing we set up amongst our own genetics community. Now, these genetic disorders are rare. So, world over, we have these platforms where you can match your rare patient with another patient world over. And so, if you get two or three patients, you know that you are all dealing and looking at similar things. And that's how new genes, etc., get identified. And so there was this family so everything starts with a family. So there was this family where the first pregnancy had agenesis of the corpus callosum, and there was some cerebellar hypoplasia. Pregnancy discontinued, autopsy done, exome done, nothing identified. Second pregnancy, similar things. And, then again, we looked at everything, again did a trio exome thinking that we had missed out things, and we didn't get an answer. And so we just had to tell them, I'm sorry, at present we don't have an answer, and we will follow up on scans. And then the message that I really want to give all our friends was that variant of uncertain significance, we will not do a prenatal diagnosis on that, because we will burn our own feet. It's a big challenge, because new things come up. And lo and behold, 2 years later, we had a gene with the phenotype exactly matching this. And we queried that database I was talking about, and we found a total of 9 children from 5 families with the same gene, same phenotype, same variant, you know. So there are things like that that inspire you. There are so many more stories like this, And that's how we found the first new gene that we identified here was, again, one child born here in my hospital, sick, died at 6 months of age, severe neonatal seizures and developmental delay. We did an exome, didn't find anything. That was the technology then. And so the parents did another pregnancy. Again, the second baby born, similar. Again, went through all that. We did a whole genome. In fact, somebody was going for learning whole genome outside. I said, okay, you take the genome. We know we are dealing with a recessive disorder. He came back with nothing. And then I sat down with that case. I said, okay, 2 affected children, let me see what it is. There were clues in the phenotype. And from those clues in the phenotype, when we sat down to match all the phenotypes of the 2 affected, we reached the group of genes that we needed to look into. And we looked into that same old exome and genome data, and we got the gene.
Okay.
So this was a new gene with a new phenotype. So there are 2 messages here. And the message is that the phenotype remains so important. It doesn't matter what technology you do. And then when we found that new gene, that was the first gene that we found here at my department. And then we have to look around for functional, and we realized that there was another international group who was working on the same gene, and they had 8 patients, and they said, okay, why don't we collaborate and publish it together so that the data is good and conclusive. And so I have to say that it is your own patients who teach you a lot, and they are the ones who motivate you to just keep moving on, because there is a lot more to be done.
Amazing, madam. Your dedication and your in keenness to arrive at what the cause is what is truly inspiring. I think we're nearly ending, but I would want you to tell us a message to the general obstetricians here, in terms of genetics, about genetics literacy, as you were talking about, which is so very important for our in our field.
Yeah, I think there are a couple of things that are really, really important. And the first thing is for the obstetrician to speak to the family about a family history. It's interesting to know how much information we can get from there. And it's just a simple simple conversation with no extra charge. So that is something that really helps, because even sometimes beta thalassemia carrier status, you realize there's an affected child in the family, and she has come to attention late because nobody, asked her.
Effect on it, yeah.
And then we should really work on doing screening for beta thalassemia and spinal muscular atrophy. But at the same time, screening is optional. We can't say that I will not see you if you don't get this test done. Sometimes patients come and tell us that story. And then, so whether it's screening for Down syndrome or doing an amniocentesis for something, it's all optional. The patient's baby, the patient is at liberty to decide what they want.
Yes, absolutely.
Yeah. And I think so, therefore, by doing multiple things which may not be required and putting all that burden on patients. So I think four things: genetic literacy, family history, beta thalassemia, SMA, and understanding that it is for the patient to decide what they want, as long as we have talked to them, explained them, and then made our documentation that we told them they didn't want to do it, which is fine. Sometimes it's the belief. It's the belief, they don't want to do it.
Yeah.
And I think also to understand that there is only so much that, an obstetrician can do. And therefore, if something is there which they're not understanding, to please refer in time.
Yeah.
Because once you refer, if the pregnancy is advanced, all genetic testing takes a little bit of time. And it's not nice to do late terminations, even if that option is there.
Yeah.
Something that we could have addressed earlier.
Doesn't
It's
mean that
very
if we wait
harrowing
that
for the
long.
lady. It's very harrowing. Very, very harrowing.
Yeah, very true. I don't think we should wait that long just because we have that option of it.
Yeah, that's true.
And madam, you are such an inspiration for, taking up genetics in our practice. So your message to the young guns who would like to take up genetics as their future prospects, because, it's always, we look at you in awe and admiration of how well you've done, but your also words of wisdom for us.
It's an amazing field.
Yes.
And it's actually transforming, if not already transformed, medical care in every specialty. And so that's why I keep saying that genetic literacy is essential. It's the right time. And so invest in it with your mind, with your brain, with your soul, and you won't be disappointed. It's going to change. It's going to change everything in the next 10 years.
Yeah.
Going to be treating disorders which we never thought we would. We would be making therapies in our country so that we are able to give it to all our patients and not say, okay, it's there in America, but we can't afford it. That is something that really bothers me.
Yeah.
So I think this is the time, and I think it's the right time to get into whether we do it in clinical practice or basic research. It's the need of the hour, and it's really going to transform medicine in the years to come.
I think it's not only in obstetrics, even in the fields of oncology. I mean, be it any field,
Every field, every field.
genetics, you cannot
Precision
say.
medicine is the buzzword now.
Yes. Yes, madam. So it was so wonderful as always talking to you. It sort of sets you at calm when you listen to you, because then we feel so enriched and enlightened by genetics as whenever you hear your talk. So thank you once again, madam, for being with us and for enlightening us with so much of genetics that you know.
Thank you, Sita. It's been such a lovely hour. Really enjoyed speaking with
Yes.
you, and it's been a privilege to be on the platform. Thanks so much.
Thank you so much. Thank you.
Bye-bye.
Bye-bye.